Hello, everyone. Thank you so much for joining our today's session. How are you all? So tonight we are going to discuss psychiatry, one of the very important topic for your exam. But before we move into that, let us introduce with you. So my name is Dr. Arshan Ahmed. I am one of the coordinator for your AMC MCQ preparation. And many of you already know that how much we are our fellow candidates to get on to this exam, right? So AMC MCQ is your first step towards your long dream to work as a doctor in Australia. And we're one of the, I can say that it's been 4 years we are we are trying to help our IMG candidates to pass this exam. And it's not only AMC MCQ. When you pass AMC MCQ, we also help you with your AMC clinical preparation, and sometimes also in the long way getting your job. Obviously, we can't guarantee your job, but obviously we can show you the path. We can show you where to look at and how to apply for a job. So this is a long step, and you are at the first step in that long way to go. But as always, try not to get stressed. Try not to think that, well, this COVID situation is going on and everything, blah, blah, blah. So what I'm going to do? Am I going to wait for like 1 year, 2 year just to get to pass this exam? And even many of you may not be able to get the exam also because of the COVID issues, but that's fine. As long as you prepare yourself fine, and then one day everything will come fine. Okay, so don't stress with that. If your dream is to be a doctor in Australia, hold on to that. Don't listen to anyone. Don't listen to your friends. Don't listen to your big brothers and sisters who might try to say that, well, getting a job in Australia is out of dream. So why you are going to kill your time preparing for MCQ and then clinical exam, which is very hard to pass also. So don't think in that way. I would say if your dream is true, you will get to that. It takes time, but obviously in one day you will be a doctor in Australia. And that's very important that you don't compare yourself with others. There will be a lot of people in this world, even like even relative or friends of you, who is not at the same level, not at the same level of your knowledge, your experience, your financial abilities, your support that you're going to have. So every person has a different perspective. Don't think like others. Always be hopeful. Always listen to the people who are successful in their lives. Okay, don't listen to others who will always try to demotivate you. So why I'm saying that, because one day I was like in your position. I did not know that how to prepare for MCQ, or like what I'm going to do in the next 2 years. I just finished my MBBS degree, and then I was thinking like, well, I don't like this. I don't like my country, so I want to go to Australia. So then I try to get to know these things from a lot of people, and trust me, like among 100 people, I would say 80% try to demotivate me. So there is a lot of demotivation going on in this perspective. And I guess many of you also heard about it. Many of you also is still now going through that. So the first thing in your mind you should have is that, well, I'm going to pass these exams. I'm going to be a doctor in Australia, no matter what. All right, you don't need to be in Australia to be a doctor in here. Wherever your country is right now, trust me, I was in the same level. I did not have anyone who were in Australia. So many of the other people say that, well, you need someone to be in Australia to get a job there. No, you don't need that. If you are true to yourself, if your dream is really true, and if you pray to your God every day that you want to be this in this country, you want to work here, trust me, your God will show you the path. Okay, you just need to trust yourself. and continue praying. That's all that's need. Okay, so a lot of talking. So I was just trying to see that if everyone joins the class, so that's fine. We'll get into that. Everyone can hear me properly. What happened with Dr. Kamrul Nahar? Cool. So psychiatry is one of the most important topic for your MCQ exam. Why I'm saying that? Because, excuse me, guys, just sorry, guys. Okay, so I was saying that psychiatry is one of the most important topic for your AMC MCQ preparation. Why I'm saying that? Because AMC knows that psychiatry is not, like, you guys are not very good in psychiatry because most of you did not get into psychiatry topic during your medical school, right? So that's very common for Asian countries. And I guess many of you or most of you are from Asian medical school. So, and that's very common that most of us did not have a fair knowledge on psychiatry. And AMC knows that in Australia, we value psychiatry a lot. Okay, if you have a very good knowledge on psychiatry, if you have experience in psychiatry in your country, trust me, getting a job in here is very easy because psychiatry is really, really important for Australian. So please make sure that you have a very good knowledge on psychiatry. All right. Now, before we move into psychiatry, I just want to get into the AMC MCQ format, the exam format. Many of you already know that, I know, but some of you might be totally new. So for you, I'll just give an introduction of AMC MCQ exam within 5 minutes. So AMC MCQ, it's a computer-based exam. That means that you have to be in a computer and there will be 150 questions that will appear one by one in the computer. For 150 question, there is 3.5 hours duration. And among those 150 questions, 120 will be scored questions and 30 will be pilot questions or non-scored questions. But unfortunately, you will not know which one is pilot and which one is scored. That means you have to get all the questions give the same value because you don't know which one is scored and unscored. But we know that the last 20 questions that come in AMC MCQ, that's most likely are scored. So it's very important that you take your time to get to the bottom or at the end of the exam so that at least the last 20 questions you give some time and you answer those correctly because those are really important questions at the end. And they know that at the end you'll be tired and you may lose time, and some of the candidates may not get to the end of the 150 questions because of the time issues. So that's why they give these last 20 questions like high priority, and those are always scored questions. The past score is 250, but unfortunately, we don't know which question has how many marks. It totally depends. Some question has 2 marks, some question 4, 6, 8, even 10 marks. But AMC doesn't reveal their marking system. So right now, it's been going on for a long years. They are taking exam, but there is no known criteria of marking. Okay, so we don't know like how they usually mark the candidate. But what we know according to AMC, that candidates are given simple questions initially in their exam. If they get it right, then the next questions become a little hard and so on. As much hard questions you are getting right, you will get more marks in the exam. That means some of you may get all the simple questions and you think that you did really good, but still you can fail the exam because maybe the hard questions you did not get it right at all. So the marking came low. They use an adaptive scale like this. Okay, so this adaptive scale, no one knows how they score it, but if you can be on the top of this 250, then you pass the exam. Okay, so the important thing is that you need to have a fair knowledge on each of the topic that AMC usually gives questions. Again, there are a lot of variation in that. Some people get a lot of psychiatry question. Some candidate gets a like 2-3 psychiatry question, and they are really lucky because psychiatry questions sometimes can be really hard in the exam. According to AMC, this is what they are supposed to give to you. So adult health, that means medicine questions are 30%, surgery 20%, women's health, gynae and obstetrics 12.5%, pediatrics 12.5%, psychiatry 12.5%, population health, which is actually biostat and epidemiology, that's 12.5%. They don't always follow this percentage. Some of the candidates gets only one biostat question, some of them get 5 questions. So there is no known criteria for questions, but most of you will get medicine questions. Medicine surgery questions will be more than the others. But again, you have to have a fair knowledge on each of these. So medicine, surgery, gynae obs, pediatrics, psychiatry, and biostats. So these are the topics that you guys need to learn for AMC MCQ. For AMC MCQ, there is not much guideline given. That's one of the problem that all of you will face during your journey. But I would say that for AMC MCQ preparation, follow your John Muttag, the recent edition, which is the 7th edition right now. Then you can follow Kaplan, USMLE Step 2 CK books, because that's really good to have a fair theory knowledge. And then there is a lot of websites, which Australian guidelines you can find there, because Australia guidelines are vast and there is no specific guideline. That's the problem that happens, because whenever we try to solve a question, whenever we try to get into detail of a question, there is no specific guideline on anything. That's the problem, okay? But Australian guideline, if you want to follow the RACGP guideline. So we have RACGP, that's a very good guideline. Or there is AGGP. This is also a kind of RACGP guideline. So these guidelines are really good Australian guideline for your medicine preparation. For pediatrics, you have RCH guideline. That's a specific guideline you can follow blindly, and that's very good. Almost every disease that you need to learn for AMC, RCH has it. Okay. Unfortunately, for psychiatry, there is no specific guideline. Also, but you can go to this range CP guideline. That's a good one, but it's a fast thing. You don't need to go into that. For gynae obstetrics, usually we will follow the SA Health guideline. That's also good. So it's a South Australian guideline, but it's very good guideline for gynae and obstetrics. And then for pediatrics, we already discussed about it. What else we have? So surgery, there is no guideline, unfortunately. And for mental health or psychiatry, we will follow RAND CP. And the most important one is your UWorld USMLE. UWorld USMLE has a very good questions on each of the psychiatry questions or psychiatry topics that you need to learn. So we always ask our candidate to finish this UWorld USMLE by themselves, because in here you will have, like, let's say we will discuss depression today, schizophrenia today, and UWorld USMLE has few questions on that. And the answers that they have given is very vast. It not only helps you to gain your basic idea on psychiatry, but also it helps immensely to get a good marking in psychiatry in your exam. So UWorld USMLE is must to finish. If you think that you want to get a very good mark on psychiatry, or even if your luck is not very good, if you get a lot of psychiatry question, UWorld USMLE definitely will help you. All right, so we will follow UWorld USMLE. JM 7th edition has some psychiatry guideline that we can follow, but mostly we will go through Kaplan Step to CK Psychiatry. Kaplan Step to Psychiatry is a very good guideline on theory, so we have to finish that, and then we can just take help from something from JM, something from UWorld, RANCP, like that. And obviously, you can follow our lecture notes, and we have psychiatry question solvation file also. Once we finish psychiatry, then we usually try to solve many psychiatry questions in one class as much as possible. And then you can see that how theory knowledge can be incorporated in solving questions. Because to pass this exam, it's not only theory knowledge you need to know how to solve question also, because that's what matters in exam. You need to solve a question, you need to get into a appropriate MCQ answer, right? There will be 5 MCQ in the 5 options for a particular question. Out of that 5, 1 question will be your answer. The other 4 are very, very similar to the answer that you will have. So it's very important to know how to exclude those other options. So we'll show you how to do that. And there is a class coming up on 29th August that will be on how to solve questions. So it's a tips and tricks on solving the questions. Okay, so we'll get into that at that time. Those who are in the Facebook Live, I would again suggest you to come to our Zoom session, because then you will get that the internet connection is very good in the Zoom also, because what I'm doing, I'm trying to make a live session from Zoom into the Facebook. So sometimes you will be a little bit of behind from what I'm talking. And even sometimes if there is any network issues, the Facebook Live can become a little fuzzy. So if you can come to the Zoom so that I can only look into one platform, and it becomes easier also. And if you have any questions, all right, so just write it in the comment box. I'll get to that. And the Zoom link is already given in the first aid AMC MCQ group. So if you just scroll down there, you should be able to get it. All right, so lots of talking and introduction actually. So now we are going into the psychiatry lesson. For psychiatry, we will mainly follow the Kaplan Step to CK guideline, and some other things I have already incorporated into this note, so we can follow that. So for psychiatry, tonight we are focusing on the most important topics, which usually comes very, very frequently in AMC MCQ. So depression we will cover, bipolar disorder, grief, schizophrenia, and other schizophrenia-related conditions we will go through. And also some clinical pharmacy we will go through in terms of depressions and schizophrenia. All right, so now depression. If you guys don't understand anything at any point, write it in the chat box so that I can check it and I can answer your questions. Okay, this is how we take class also, because there is a long list of candidates in here. If everyone start talking through their mic, it becomes a haphazard class. So to make sure there is quiet place in the class and there is not too much noise, I always make sure that guys write it in the chat box, whatever questions you are having in your mind. Okay. So for depression, let's say that a 70-year-old woman was recently admitted after her son informed the doctor that she had been doing very poorly over the last few months. The patient reported 30-pound weight loss, decreased concentration, feeling of helplessness, hopelessness, decreased energy, depressed mood, and decreased sleep. Now, for depression, there is a DSM-5 criteria that you need to remember. The criteria says that at least 5 out of these 9 symptoms should be there for at least 2 weeks. The term is 2 weeks, not 2 months. A lot of candidates get it wrong. Okay, to diagnose someone with major depressive disorder, there have to at least 5 of these 9 criteria. Among those 5 criteria that you need, at least 1 should be there out of these 2. That means patient should have either depressed mood or loss of interest. So these 2 are the vital criteria for making someone a diagnosis of MDD. So what I said, that at least 5 out of the 9 criteria should be there for at least 2 weeks. And among those 5 criteria, at least 1 of these 2 should be there. So either depressed mood or loss of interest. So what are the other criteria? You can easily remember by MCQ. What is MCQ? M is mood changes. So mood can be low mood, or sometimes in the adolescent patient, they are not low actually, but they comes with irritability. So mood changes, either low or irritable. Then sleep changes. So that's for S. Sleep changes in depression can be insomnia or hypersomnia. So some people usually get difficulty in sleeping, or atypical depression usually presents with hypersomnia. Then loss of interest, so that's for I. Loss of interest in psychiatry term, we call it anhedonia. So what we call it? Anhedonia. Then you have guilt. So patient with depression, they feel guilty, hopeless, worthless. E for energy, so lack of energy will be there. C for concentration, so lack of concentration. A for appetite change. So most of the depressed patient, they have a loss of appetite, but atypical depression patients, sometimes they can get increased appetite. Because of loss of appetite, they also tend to lose weight. But in atypical depression, because they have hyper appetite, you can say, so they can also gain weight. So both can be there. Then P for psychomotor changes. In psychomotor changes, you have psychomotor agitation or psychomotor retardation. Most of the time, depression patients have psychomotor retardation, which means that they usually tends to become very slow. So they say that, doctor, I become very slow in everything that I'm doing. So slow down on things. That's psychomotor retardation. And the most important thing that you always need to ask a depressed patient is the suicidal ideation. In many questions of AMC, this is a vital thing that they ask, that they give a scenario of depression and they ask you that what is the most important question that you should ask in this patient? So that's suicidal ideation. Okay. Every patient who has depression, for the first time when they present to your clinic, the first thing that you rule out is the risk assessment of that patient. And that is actually we assess by their suicidal ideation. They are having any active suicidal thoughts or not. Okay, so that's very important. So that's your MCQ that you need to remember. So this is what exactly is written in DSM-5 criteria also. So as you can see, depressed mood, loss of interest, change in weight or appetite, change in sleep can be insomnia or hypersomnia, psychomotor agitation or retardation, loss of energy or feeling tired or fatigued, worthlessness or guilty feeling, concentration problem, and suicidality. So this is how we diagnose major depressive disorder. The 2 key criteria to diagnose someone with MDD is depressed mood and marked loss of interest, which we call anhedonia, as we told. And that should be at least for 2 weeks. And other criteria, we already get to know into that. There are also other disorders related to depression. One is your major depressive disorder that we just now get to know into that. There is another condition which we call persistent depressive disorder or PDD. This comes in exams. They ask the diagnosis and they give a scenario like that. So it's a long-standing mild depression for at least 2 years. So if someone have a history of mild depression, which persists for at least 2 years or more, then we call it as a persistent depressive disorder. Or sometimes we even call it dysthymia. Now, major depressive disorder is divided into 3 categories depending on their severity. So it could be mild, moderate, or severe. Sometimes major depressive disorder can have psychosis associated with it also, and that's a very severe form of depression. Okay, so these are the main important subtypes of depression that you should know. So as I said that if psychotic features are associated with a depressed patient, like they can see things, they can hear things, like they're having hallucination, delusion, that means they are having active psychosis. For someone having MDD with psychosis, they have very worse prognosis. All right. And the atypical features that you can get, one is increased weight because of increased appetite and increased sleep. These are called atypical features of depression. Now come to the depression in children and adolescents. Remember one thing, adult present with definitive criteria of MCQ. But children and adolescents can have depression, but they don't come to you commonly. And the most importantly, they don't come to you with a full-blown criteria of MCQ. That means they don't come to you with low mood or loss of interest like that. They usually come to you with feeling irritable. Okay, so irritability is more common presentation of depression in child and adolescent. They can also present to you with feeling of helplessness, worthlessness, and despair. They can have loss of interest, and sometimes given in the question that that the child, or you can say like 15-year-old patient brought in by the mother and having recent onset of irritability and not going out of the room, always staying in the room, lying down, okay, not talking with her usual friends, not going out to see the movie or play with friends. So that's one of the presentation of depression in adolescent. All right, so irritability is more common. So as you can see in children, irritability may be more prominent than sadness. They can also have difficulty getting into sleep, not enjoying meals, poor concentration, low self-esteem. Suicide are common in adolescents, so we have to actively ask those questions to find out if this patient having any active suicidal ideation. Now, a question comes for you. What is the best antidepressant for adolescent? We haven't got into the treatment yet. I'll go into that. So for treatment of severe depression or even moderate depression, we start SSRI, SNRI, TCS. But question is, what is the best treatment or what is the best antidepressant for adolescent? Anyone? Fluoxetine. Very good, Dr. Nisha, Dr. Oishe. Yeah. So it's fluoxetine or even fluvoxamine, whatever it is given in the stem. So if it is either fluvoxamine or fluoxetine, both of these two are usually the first line choice of antidepressant. If you're going to give antidepressant, then either of these two should be given. And it comes in exam. There is a question in your AMC handbook also. So as I just came into the AMC handbook, please go through the psychiatry session of AMC handbook. It has a very good explanation of a lot of conditions. All right, now let's move on. Recurrent brief depression. There is a term called recurrent brief depression, which means that a patient coming to you with recurrent episodes of depression of short duration, about 3 to 7 days, and it comes very often, sometimes even monthly, which means MDD, to diagnose someone with major depressive disorder, you need at least 2 weeks symptom. But for brief depression episodes, they usually don't follow that criteria. They usually have a very short episodes, 3 to 7 days of brief depression episodes. In this case, if you are thinking about starting antidepressants, it has no role. So as a rule, antidepressants are ineffective in this patient. So because why? It's just for a short duration. Antidepressant needs some time to give you the effect. So if you give antidepressant in this patient, it doesn't work. Lithium is an alternative medication for long-term use, but for this patient, initial management should be a psychotherapy or CBT. If CBT doesn't help, then for a long-term prophylaxis, you can give lithium. But antidepressants like SSRI doesn't work in here. So very important thing to know. There is a condition called seasonal affective disorder, not very important. This case is usually like they call it winter blues. During winter time, some people tends to get depressed, and that is called seasonal affective disorder. Treatment is psychotherapy, phototherapy, and even sometimes SSRI can be given. But better option is psychotherapy or phototherapy. Now come to the management guideline. Very important question comes frequently from here. As I said, according to the severity, mild, moderate, or severe depression can be there. In case of mild depression, you will not get that patient's level of depression doesn't affect their social, familial, occupational, or you can say personal life. Okay, so mild depression doesn't affect their day-to-day life. Moderate depression, it affects a little bit, but severe depression, it affects their familial life, social life, occupational, professional, every life is affected by severe depression. If someone have suicidal ideation, that's obviously severe depression also. Okay, so this is how we differentiate. For mild depression, the best management is CBT or cognitive behavioral therapy. What is actually cognitive behavioral therapy? It's given by psychologist. Remember, it's not psychiatrist who gives CBT, it's a psychologist who gives CBT. And in CBT, psychologists try to listen to the patient that what's actually bothering her. And then after listening, the psychologists try to put positive thoughts in place of negative thoughts or feelings she is having. So she actually, the psychologists try to show her the positive way of thinking, and actually helps her to deal with the stress that she's having. So that's CBT, and that's very, very important management for someone having a mild to moderate depression. In moderate depression, again, you can start with CBT. If that doesn't work, then you can go for antidepressant. But for severe depression, antidepressant should be your initial treatment, not your CBT. CBT will not work in here only. You can always add CBT to maintain it, but the initial treatment should be antidepressant in severe depression. Sometimes if severe depression doesn't get better with antidepressant and CBT, the last option will be going for ECT or electroconvulsive therapy. Now let's have a look to this one. A question. It's a very big question, and unfortunately, you can get this sort of question in your exam. Look at this question, read it carefully, and always it's important to pick up the important thing. So 72-year-old Comes to the office due to the worsening depression and insomnia since his wife died 7 months ago. The patient experienced lethargy and episodes of tearfulness. He has little interest in socializing with his married friends anymore. He has attended 3 sessions of psychotherapy and expresses appreciation for the referral because he likes the therapist. However, the patient continues to feel depressed, now experiencing severe insomnia. He has difficulty falling and staying asleep, frequently lying awake at night. He feels very guilty about her death. Okay. The patient experienced a moment of severe depression last week in which briefly he thought of suicide because there is nothing left for me in this world. Whenever you see suicidal ideation, that's become a severe depression immediately. However, he adamantly told that he would never act on these thoughts. Physical examination shows loss of weight also. Which of the following is the most appropriate next step in management of this patient? Now, even if you are not able to say that this is the MDD or not, then look into the criteria. What does he fulfill the criteria or not? So let's see if we can find out the 5 symptoms. So he's having depression or low mood, right? So that's one criteria. Lethargy, lack of energy, that's 2 symptoms. Little interest, number 3. Insomnia, 4. Guilty, 5. Already 5 is done. Loss of weight, 6. Suicide, 7. So 7 symptoms we have got. So this is obviously MDD, and you can see it's for 7 months this is going on. So obviously this is a severe major depressive disorder. Now for this patient, what will be your treatment? Increase frequency of psychotherapy session to twice weekly. Prescribe amitriptyline, which is a TCA, and continue psychotherapy. Prescribe mirtazapine and continue psychotherapy. Prescribe zolpidem for insomnia, continue psychotherapy. Reassurance and psychotherapy, or recommend electroconvulsive therapy. This patient, as a treatment, he was only getting psychotherapy, right? So for severe depression, this is the time you start treatment or treatment with antidepressant. So just cross out all the psychotherapy only option. Okay. Now you have ECT. ECT is not recommended yet because you haven't even tried any medication. So cross that out. So you have 3 medications in your hand. Zolpidem, yes, you can give it for insomnia, but we don't just treat insomnia because it's a part of depression. You have to treat depression. So giving just zolpidem for insomnia will not work. Now we have TCA and mirtazapine. Remember one thing, TCA is no longer the first-line treatment. Rather, mirtazapine is a very good antidepressant. And why it's very good in this patient? Because having severe insomnia. Mirtazapine, its side effect is that it makes people over sedation. So over sedation means that patient feels sleepy in this case. Now this patient having severe insomnia, so obviously you can give mirtazapine to this patient, and that will also help with the insomnia he is having. Okay, so don't go for TCA when you have SSRI, SNRI in your hand. Okay. Clear, guys? Any question? No, it cannot be complicated grief. That's a very good question, Dr. Vishi. So I understand why the grief thing came up in here, because this patient lost her wife 7 months ago. Okay, so it can be grief, but normal grief should be resolved within 6 months, and after 6 months they should get better. And the next thing, yes, after 6 months, if still he gets the grief kind of symptoms, it could be complicated grief. But complicated grief can only be diagnosed if that patient doesn't fulfill the criteria of other psychiatric disorder. In this case, this is fulfilling the major depressive disorder criteria. If someone fulfills the criteria of MDD, even if he is grieving, the diagnosis will be MDD. Is this clear to understand that, let's say this patient was having these features just after 2 months of her wife's death. So he should fall under grief time duration, right? But if at that time he fulfills the criteria of major depressive disorder, the term will not be grief anymore. Then it becomes a depression case. Because someone losing wife or anyone who is very close, it can be grief, but if the grief fulfills the criteria of depression, then we no longer call it normal grief or complicated grief. We call it as it is because it's fulfilling the criteria. It becomes depression. And why it's the what is the difference in option B and C, Dr. Arushi? Amitriptyline is a tricyclic antidepressant, which is no longer a first line medication in case of treating depression. It's a 72-year-old. Amitriptyline can cause fall and postural hypotension and lots of other complications. We don't give TCA in this age group. Like not even if you have SSRI in your option, if you have SNRI, like let's say venlafaxine or duloxetine in your option, if you have mirtazapine, these are atypical antidepressant. Mirtazapine, okay? If we have these in option, we don't give amitriptyline because those are second line medications. And these are first line, SSRI, mirtazapine, venlafaxine, these are all first line that we give accordingly. There is no guideline on how to differentiate exactly on moderate and severe depression. It's a thing like in between mild to severe, if someone having like what you can say, moderate means that the patient doesn't have suicidal ideation, but it's affecting their life a little bit. Okay, so there is no specific guideline on that how we can measure someone having a moderate or someone having a severe depression. The guideline is that it's a perspective according to the clinician. You know that this patient is having a moderate or severe depression. That's why the guideline is the treatment will be CBT and or antidepressant. So if you think that, well, this patient is still not severe, not having any suicidal thoughts, so, well, I can try with the CBT first, see if he's improving. If he improves with CBT, most likely it was a moderate depression. But even after CBT, patient continues to have the similar problem, then most likely it's a severe depression. So we should start treatment with antidepressant. So it's just as a clinician, you have to think about it. There is no guideline on that. And actually, it's not possible also to make such guideline. Yeah, it's obviously the course of treatment depend upon the response, obviously. If you think that this patient having moderate, you can think it as a moderate if it doesn't fulfill if it's patient doesn't have any problem with their social familiar life or personal life, or just a little bit of effect, still patient is going outside, going to have their work, so it's still going on, then you can start with CBT, see if it's helping. If it doesn't help, then you start treatment with antidepressant. Don't think in a complex way. In case of AMC gives the questions very clearly that it's either mild or severe. They don't confuse you with moderate thing because that's a gray area. Now come with the side effect of SSRI. That's very important to know that what are the side effects for SSRI, because this is your first line antidepressant medication. So SSRI can cause insomnia. Some of them can cause sedation, but most of them causes insomnia, sedation, appetite change, dry mouth, sexual dysfunction, GIT upset. Okay, so these are very common. Go through the others, not very important. And you can see that these are the common SSRI that we use. Fluoxetine, citalopram, escitalopram, sertraline, paroxetine, and fluvoxamine. If you look at here closely, you will understand that all of them causes sexual dysfunction. All of them causes gastrointestinal upset. Okay, so and other than this, some of them causes insomnia, anxiety, drowsiness, all these things are pretty common in here also. So give it a read in your own time, the side effects. You don't need to memorize everything, that's the point. For mirtazapine, the specific side effect that you need to remember is that it causes severe sedation. That's why in depressed patient, someone having main problem is insomnia, we can try mirtazapine because it can make them sleepy. Other thing that it can cause is that it can cause constipation, serum cholesterol can be increased, weight gain can happen also. Then come to venlafaxine side effect. This is a SNRI. SNRI is also a first line medication if your SSRI doesn't help. So normally we try with the SSRI things like fluoxetine, citalopram, paroxetine, sertraline. Those are pretty commonly used in depressed patient. If that doesn't help or if it's not well tolerated, you can try venlafaxine, you can try mirtazapine. These are other drug class that we use. So venlafaxine, its main side effect that you need to remember that it causes insomnia. So someone having main complaint as insomnia, you should not give venlafaxine to them. Other than this, it causes hypertension. So it's very important. It comes in exam also. Someone having underlying hypertension, you don't start venlafaxine with them. And also, you start venlafaxine in a patient, you regularly check their blood pressure. It can increase the seizure threshold. And most importantly, let's say a 72-year-old patient having severe depression, and few months back you started venlafaxine in that patient. Now patient present to you with acute confusion, loss of alertness, okay, and loss of cognition also. So acute confusion happened just after a couple of months. What do you think that has caused this confusion? Anyone? Yes, very good, Dr. Oishi. Hyponatremia. Hyponatremia is a well-known complication of venlafaxine. So, and adults, like elderly patients, are more prone to get this hyponatremia. And hyponatremia can cause confusion in elderly. So always be very careful. Exam questions come in this way. So you need to know this side effect so that you can easily pick up, or you can think that, well, this patient was on venlafaxine and after starting it, now this elderly patient got confused. So what's happening? So let's check the electrolyte, and you checked electrolyte, sodium is very low and it's treatable, right? So that's very important to know. The next side effect of SSRI is important, comes in exam, known as serotonin syndrome. What is SSRI? It's a selective serotonin reuptake inhibitor, right? So this SSRI increase serotonin level in your blood. If you give someone two drugs which can increase serotonin, that can cause serotonin syndrome. or you suddenly increase the dose of a serotonergic drug, it can cause serotonin syndrome. Even not only the SSRI, if you give other antidepressant, like you give SSRI, like a patient was on sertraline and she went to another doctor and that doctor started her with TCA, like amitriptyline. Both of these increase serotonin in the blood. So what will develop? Serotonin syndrome. Same with, if they start with MAO inhibitors, same thing will happen. Other than this, opioid, especially tramadol, is notorious to cause serotonin syndrome. Some of the illicit drugs like MDMA, those things can also increase it. Antiemetics like metoclopramide can cause serotonin syndrome. Lithium can cause it, and selegiline, which is the MAO inhibitors, can also cause it. So these are very important. It comes in exam in this way. Just the stem that I just told to you, it comes in this way. How they present? If someone develops serotonin syndrome, they develop usually three type of alteration in their body. One is their cognitive alteration. So mental status will be changed. They can get agitated, confused. They can develop seizure, convulsion. Okay. Then muscle tone will be altered. That means they can develop tremor, shivering. They can have hyperreflexia. Very, very important clues in the exam. So hyperreflexia, tremor, autonomic instability. So they can have increased sympathetic overdrive in their body, causing hypertension, tachycardia, even very high fever and diarrhea. If you look at this patient, this is exactly how they look like. So they will be having overdrive of their autonomic activities. Because of increased autonomic activities, if you look at their pupil will be dilated, mydriasis will be there, they will be very sweaty, high fever will be there, agitated, tachycardia will be there, hypertension or hypotension can be there. They can have diarrhea because peristalsis get excessive. They can have clonus, hyperreflexia, and tremor. So these are all the features of serotonin syndrome. What is the treatment of serotonin syndrome? That patient needs to immediately stop all the serotonin containing drug she is getting. So all the offending agents which can possibly increase serotonin in her blood should be stopped immediately. All right, and refer this patient to the emergency department. Now let's say you stopped serotonergic drugs. Still patient is confused, patient develop convulsion, seizure, and very unwell. What you can give to that patient? You already gave all the supportive measures like cooling blanket to make her fever to lower down. You have given IV fluid, like a cold IV fluid. Everything has been done, but it's not working. Yes, very good. You can give cyproheptadine. It acts as a kind of antidote against this serotonin. Now, there is a term which we use very commonly, neuroleptic malignant syndrome. Serotonin syndrome is a complication of SSRI or antidepressant, whereas NMS, neuroleptic malignant syndrome, this is a complication of using antipsychotic drugs. Someone started with antipsychotic drugs, let's say the first generation or typical antipsychotics, or even second generation antipsychotics, they can develop this NMS. How we differentiate between these two is important because single person can be on both antidepressant and antipsychotics. And it can be difficult to say that is it a serotonin syndrome or neuroleptic malignant syndrome. In this case, you look on some of the things. Serotonin syndrome comes abruptly, neuroleptic malignant syndrome gradually. If you look at the neuromuscular finding, this patient, serotonin syndrome, developed tremor and myoclonus. But neuroleptic malignant syndrome, the main complaint is diffuse rigidity of their muscles. Also, very important differential factor is these two. Reflex will be increased in serotonin syndrome and decreased in NMS. Pupils will be dilated here and normal in here. So very easy, if you look into these three things, then you can easily differentiate between these two. We'll go into the neuroleptic malignant syndrome when we go into the schizophrenia and antipsychotics. Now come to the duration of treatment and how long we have to treat this patient, when we can stop it and everything. If antidepressant medication is used and patient is well now, remission is achieved, then it is recommended to continue it for a minimum of 12 months for someone having depression for the first time. So first time depression, continue it for 12 months, even if patient is totally fine. If someone develops recurrent depression, then we need to continue it for 2 to 3 years. Okay? So 12 months for initial episode, 2 to 3 years for recurrent depression. And these are the risk factor of relapse. Give it a read in your own time also. Now, before we go for a break, I want to discuss a little bit more about the medications. Two important things comes into my mind right now is that one question I'm asking, a patient was diagnosed with severe depression and he developed severe nausea, vomiting, and abdominal pain after 2 weeks of treatment with sertraline. What do you want to do? So it's a sertraline-induced GIT upset. So it's a very common thing because sertraline causes GIT upset more than any other SSRI. So in that case, the guideline according to your AMC handbook also that you can switch to another SSRI, or in this case, what you will do, you will gradually reduce the dose of sertraline, okay? And usually we will switch to another SSRI. That means the medication of the same group. You don't need to change it to other group. That's the main guideline, because in the option you will get switch to fluoxetine, switch to amitriptyline, switch to mirtazapine. So lots of other drugs class will be there. So the guideline is you gradually taper the sertraline. Okay. Now I will come into how we change this drug of antidepressant. So the guideline will be switching this medication, the sertraline, to another SSRI. Okay, keep that in there. I will come in to that point, that how we change medication, especially antidepressant. Just give me 1 minute. The next question for you is that someone is on paroxetine, and that's also for severe depression, and you started this paroxetine for, let's say, for 3 weeks. Now the patient developed sexual dysfunction. And because of the sexual dysfunction, he is also having difficulty in his marriage. What do you want to do? The guideline in here is that all the SSRI has a kind of similar percentage of causing sexual dysfunction. So if you switch to another SSRI, the same thing might happen. So there is no guideline in here that you will switch to another SSRI. So in this case, what we do, there are options. First, you can try to reduce the dose of sertraline or paroxetine that you, but this reduction of dose has only 10% effect of improving the sexual dysfunction. So it's not a very good option, right? The next thing, reassurance doesn't work where someone is losing their wife for having sexual dysfunction, right? So reassurance only will not work. You need to act on that. Number two is you can switch this antidepressant to another class of antidepressant. That means you can try SNRI. The better option is, yes, bupropion. So the newer atypical antidepressant you can try. So bupropion is a good one. Nefazodone is a good option. Okay, so those antidepressant works pretty well. So switch to another class of antidepressant will be a better option in here. The third option is that if switching to another antidepressant doesn't work, then you can add sildenafil, which is the Viagra, with this antidepressant. But that's the last option. You will not just add sildenafil to everyone having sexual dysfunction for SSRI. So better option is that you'll just switch it to another antidepressant group which has lower sexual dysfunction rate. Clear? So very important, comes in exam frequently. Okay, so good idea would be like, let's say if someone is on maximum dose of sertraline, like in one of the exam question I have seen that they've given you in this way that patient is on sertraline 100 milligram and depression is well controlled, but he has developed sexual dysfunction. What do you want to do? If someone getting 100 milligram sertraline and their depression is well controlled, you can first try reducing the dose to 50 milligram because 50 milligram is also a good dose of sertraline. So initially you can just try with that. Initially, if someone getting maximum dose of antidepressant, then you can just reduce it and see if it is helping or not. But let's say that patient is already on 50 milligram sertraline. You cannot lower down that. So in that case, you have to switch it to another group of antidepressant, which has lower side effects of sexual dysfunction, not to SSRI, to other newer antidepressant like bupropion, nefazodone, those drugs. Okay, clear guys? The next one is how we switch antidepressant. It's a very important topic that you need to learn because otherwise you can make problem in your own practice also. How? Because you can induce serotonin syndrome in patients. So what we need to think about when we change antidepressant, we don't follow that criteria that we will taper it down and we will start another drug and we will increase the drug. Not like that, because when you stop SSRI, that stays in your blood for few days. Most of them stays for 2 to 3 days, but fluoxetine can stay even for a week. So that's why you need to give a washout period before you start another antidepressant. Okay, so washout period means you give a time when you don't give any antidepressant. You give the body that time to get rid of the initial antidepressant that he was getting. So let's say patient was on sertraline, now you want to start fluoxetine. So you gradually taper the dose of sertraline and one day you stop it totally. You give a washout period of few days, like let's say 3-4 days, and then you gradually increase the dose of fluoxetine to the maximum tolerated dose. So what you have done, you have given a washout period. But what if you start antidepressant during that washout period? So you will think that patient is not on any antidepressant. So let's give him another antidepressant. But at that time, in his body, still there is serotonin, because body in the blood, even after you stop antidepressant, it stays for a few days. So that time is a vulnerable time for patient to develop serotonin syndrome. So this is the criteria of changing or switching antidepressant. They will not develop withdrawal symptoms because you are gradually tapering the dose. When you taper something gradually, they don't develop withdrawal symptom. If you stop it altogether at once, they develop withdrawal symptom. That's why we taper it down, right? And another question is that when you start someone with SSRI, it at least take 4 to 6 weeks to give the effect. So wait for 4 to 6 weeks before changing the drug if it doesn't help. So the consensus in here is that you started SSRI in a patient, and patient should be warned that they will not get better within a day. They will start to feel better within 4 to 6 weeks. So if they don't feel any better, like nothing has improved even after 4 to 6 weeks, then you can change to another antidepressants. Okay, but if in 4 to 6 weeks patient has improved a little bit, then you can continue the drug for 3 months to see that in these 3 months patient is improving or not. Okay, but you see the efficacy after 4 to 6 weeks. If patient doesn't get any improvement from the start, then you can change the drug after 4 to 6 weeks. But if they started to feel a little better but not the full one, that's fine, because it means the drug is working. In that case, you wait for 3 months to change it to new drugs. Okay, clear? So that's pretty much everything about the depression. Let's take a 10-minute break now. Then we'll move into the next topic, bipolar disorder and schizophrenia. Are you guys enjoying the session? It's a lot of information you might be getting, but trust me, all these things are so much important for your exam. Good, great. So let's take a 10-minute break and then we'll start again. Thank you. Well, let's start again. So the next topic that we are going to start now is the bipolar disorder. So bipolar disorder is also one of the other affective disorder. When I say affective disorder, affect means mood. So the most two important mood disorder that you usually get in your practice is either depression or bipolar disorder. So both of them are pretty important affective disorder. Now the bipolar disorder, that means a patient is hanging at the highest and lowest area or phase of a pole. So let's say this is the pole. Sometimes this bipolar disorder patient is in manic phase. That means at this phase, they feel really good, having euphoric mood, all right? Everything feels really better, like more than usual. And then at the other end of the pole, they feel really low and they are having a depressive phase at that time. So when someone have these two things in a single patient, so sometimes they feel depressed, sometimes they are having hypomania or manic disorders, that's when we call them as a bipolar disorder. So bipolar is a broad term to describe a recurrent illness with episodes of either mania or depression with return to normal function in between. So sometimes mania, then return to normal function, and then again going to the depression. So that's why it's very important, like especially young patient coming to you with depression features, you should always ask them that, have you ever felt really high that I should know about? Because if they had those phase that when they felt really high, that means that this patient can be a bipolar patient, not only depressed. So very important thing to learn about it. Because if you just start antidepressant in a patient with underlying bipolar disorder, you can aggravate mania in that patient. So that's very important. So any patient who is having depression, you should always ask them that anytime do you feel really high? If they say yes, then you should think about it could be a case of bipolar disorder. We'll move into detail about it. Let's go on. So what is the DSM-5 criteria for a manic episode? Mania means that a patient will have at least 1 week of abnormal, elevated mood with 3 or more of the underlying features. So they will have either inflated or excessive self-esteem or grandiosity, decreased need for sleep, very talkative or loud speech, racing thoughts or flight of ideas, easily destructible, increased goal-directed activity. That means they will involve themselves with lots of activities they usually don't do. Excessive activity with painful consequences. And if it is mania, it will impair their social occupational life also. And that's need hospitalization. This is the mnemonic that you can easily remember to diagnose mania in someone. So dig first. D for destructible. So there will be how a manic patient usually present, that manic patient usually brought by other person, like partner usually bring them, because partner usually understand that this is not usual for this patient. Okay, so usually partner will brought up the patient will feel really good and they say, oh, why I should be in your GP clinic, because I'm feeling really good. My partner is feeling like I need to come here. So something like that is their usual presentation. They present in a way that they feel really good. They don't need to sleep at all at night, and they feel excessive energy. So just the opposite of feeling depressed. So see the destructibility, they are poorly focused and they think multiple things at the same time. So they think like they are going to get a Nobel Prize. They think that they are going for a swimming class. They are going to get into a physics club, computer club. So a lot of things they do at the same time. Insomnia, so decreased need for sleep. It's not they're having difficulty with sleep. They don't feel like sleeping. They have grandiosity, that's for G. Grandiosity means that they feel like they are superior to others. They have superpower, all right? So inflated self-esteem. Then flight of ideas. Flight of ideas means they jump from one idea to others. They have these racing thoughts. So sometimes they feel like, well, I need to open up this business. Then suddenly they think, no, I should open up that business. So they're having these multiple ideas and they're having jumping from one ideas to others. Increased goal-directed activities, like someone who usually don't want to work, just very lazy, wants to just lay down in the couch and watch movies for a long duration. Suddenly that person wants to go do a lot of things. So increased goal-directed activities. Speech become pressured or talkative. So there's a very common features. They talk loudly, they are very talkative, loud, and pressured. Speech will be there. Thoughtlessness, which means they will take lots of risk, like they will go for unusual sexual intercourse, like they will say that I've like overdrive of their sexual experience. So not like they say that, okay, I feel like having sexual intercourse with a lot of unknown people. So increased sexual drive is one of the features of mania. Financially, they spend a lot, okay? Then they go for travel, they buy something which they can't afford also, and reckless driving. These are all thoughtlessness or risk-taking behaviors that you can see in a mania patient. The main feature is elevated or euphoric mood. With that, at least 3 of these features will be there to diagnose mania. Mania duration is important. It should be at least 1 week, and level of functioning should be impaired by mania. So when you diagnose someone with mania, these things should be there. At least 1 week duration, and that affects their functionality. Because why it's important, there is a term known as hypomania, in which the duration is less than a week. Features are same, but it doesn't affect their functionality. So that is what we call hypomania. Hypomania, mania both fulfills the criteria of bipolar disorder. Okay. Now, if you look at here, there are 2 types of bipolar disorder. One is bipolar 1 and another is bipolar 2. That's why this mania hypomania matters. So bipolar 1 disorder has at least 1 manic episode in their life. With that, they usually have a depressive episodes on and off. So when there is mania with depression, that's bipolar 1. If hypomania with depression, that's bipolar 2 disorder. Okay, so this is how you differentiate. If someone only developed mania, only developed hypomania, but no classic mania episode, that's bipolar 2 disorder. If you look at this stem, this is how they present. A 19-year-old college student is taken to the school counselor after he fails several classes. Patient is enrolled in numerous classes, that means lots of goal-directed activities, most of which have conflicting times. His grades are poor, yet he seems undisturbed by this. He is also enrolled in numerous organizations such as chess club, drama club, student government, sports, and at least 2 other fraternities. Pressured speech and having psychomotor agitation. Psychomotor agitation means everything becomes quicker, whereas psychomotor retardation is everything becomes slower. Okay. So this is how they usually can present to you. Now come to the management. Management of acute mania, very important, comes frequently in exam. Acute mania is medical emergency and they need immediate hospitalization. Even if they don't want to get admitted, there is Involuntary Mental Health Act that requires involuntary admission of this patient to the hospital for the safety of themselves and others. The most effective treatment for acute mania is the antipsychotic. So the first line drug will be either olanzapine or risperidone. Nowadays, if you want to choose between olanzapine and risperidone, you choose risperidone as your first line antipsychotic, because olanzapine causes a lot of metabolic syndrome as their side effect. In Australia, we don't use olanzapine as a first line anymore. We can use risperidone. Okay, but remember one thing: for acute mania, antipsychotics should be given first. What are the other second line drugs for acute mania? You can give haloperidol, which is a first generation antipsychotic. You can give other second generation antipsychotic like aripiprazole. Lithium can be given. You can give a mood stabilizers like sodium valproate or carbamazepine. So these are all second line. Remember this because in many cases I have seen that these options are not there. In your MCQ, the question is acute mania, but no antipsychotics are there. Then you need to choose between this second line. So you need to remember these drugs. If someone is very violent, all right, like a mania patient can become very aggressive and violent, then you cannot give medication orally because they will not take it. At that time, you can give haloperidol IM or IV. Better is IM because you can give it at any time. And as soon as they become stable, then you can start oral medication. Prophylaxis. The lithium is given as a prophylaxis for bipolar disorder. So if someone has 2 or more episodes of either mania or depression in the previous 4 years, that patient will need a prophylaxis. So recurrent episodes of either mania or depression in the last 4 years that require prophylactic agent. And the best prophylactic agent is lithium. Okay. If lithium is not in the option, then you can give second generation antipsychotic agent like risperidone or olanzapine, or you can also give some other mood stabilizers. But the best is lithium always. When you give someone lithium, you need to use it for a long-term duration, at least 3 to 5 years. Lithium can cause toxicity because it has a very low threshold of causing toxicity. For that reason, we measure plasma level of lithium, like at least every 3 to 6 monthly, you need to check this lithium level. Normal lithium level is between 0.6 to 0.8. Why it is important? Because lithium can cause lithium toxicity. How they present? If it's mild toxicity, usually GIT upset is there, so you can get nausea, vomiting, abdominal pain, even tremor, hyperreflexia, ataxia can be there. In case of moderate, they usually develop muscular rigidity, hypertonia, and hypotension. In case of severe lithium toxicity, they usually develop cardiovascular collapse, okay, or sometimes even seizure, coma. So lithium toxicity, if it's severe, it usually involves either cardiac or kidney. So it can cause nephrotoxicity as well. Especially it can cause nephrogenic diabetes insipidus. Okay. Now, the treatment, if someone develops lithium toxicity and it hasn't involved their cardiovascular system or the kidney, that means it's not severe. In that case, the only treatment is making them hydrated. So give some normal saline, make them hydrated, because dehydration is usually very common. And in that case, just admit the patient, measure the lithium level, and maintain hydration. If you find someone that they developed cardiovascular collapse, like let's say ECG involved, there is myocardial ischemia-like feature, STT wave changes, or they developed, let's say, kidney failure, increased creatinine, urea, okay? In that case, what is your treatment? Anyone? So the question is, for severe lithium toxicity, what is your usual treatment? Obviously, you should stop lithium, but like after stopping lithium, yes, Dr. Oishi, very good. So dialysis, that patient needs dialysis. Okay. And also, if someone's lithium level becomes more than 4, that patient also needs dialysis. Apart from the side effects that I told, it can also cause tremor, it can cause weight gain, it can cause hypothyroidism. Dr. Shumaila, you can't record this because I am recording it, and recording will be given in your Facebook group. So you can listen from there if you need to go now. That's fine. Okay, the next thing which I was talking initially, that if someone having depression now, and somehow you got to know that this patient also had a hypomania or manic episode, that means this patient is having bipolar disorder. And at the moment, he is having depressed phase of bipolar disorder. Someone is having bipolar depression. If you only give antidepressant, you can aggravate mania. So the recommended regimen for those patients, you will start antidepressant. With that, you have to start any of these drugs. So you can start lithium or any other mood stabilizers. Even you can use antipsychotic. But the best one is to give lithium because you can use it for a prophylaxis also. And then antidepressants are usually withdrawn within 1 to 2 months because of a propensity to precipitate mania. So after 1 to 2 months, you can stop antidepressant and continue with the lithium. Very, very important. It comes in exam frequently. So make sure bipolar depression, you give both antidepressant and lithium. Now let's solve this question. A 27-year-old man is brought to the office by his wife. See that I always tell you that they are brought by their partner due to her concerns that he has not been himself for the last 3 weeks. She says that he is depressed and withdrawn, sleeps 14 hours a day, has no energy or interest in looking for work or participating in activities. So loss of interest, loss of energy, feeling withdraws on depressed, sleeping problem. Patient was hospitalized 6 months ago for an episode in which he became aggressive. This occurred when she confronted him about staying up all night, gambling away their savings, investing a large sum of money in a startup of internet company that soon went bankrupt. At that time, patient spoke very rapidly and having a brilliant plan to achieve world peace. He also experienced a similar episode 2 years ago and improved, but discontinued treatment shortly after. Which of the following medication are the most appropriate maintenance treatment for this patient? Question, understanding a question is also important. They're asking the most appropriate maintenance treatment for this patient. So what do you think this patient has got? Bipolar depression. At the moment, he is depressed. Previously, he had a mania or hypomania, right? So this patient having bipolar depression. So you have to give an antidepressant with some antipsychotic or mood stabilizers. So you have option of carbamazepine fluoxetine, lithium quetiapine, lithium sertraline, lurasidone risperidone, valproate clozapine, valproate haloperidol. Now look for excluding options. Carbamazepine is a mood stabilizer. Fluoxetine is a SSRI, so it's a valid option. We can keep it. Lithium quetiapine, both of them are mood stabilizers. No antidepressant in here. Lithium sertraline, very good option, I would say. Lurasidone antipsychotic, risperidone antipsychotic. Valproate clozapine, both One is mood stabilizer, another is antipsychotic, both for hypomania or mania, not an option. Valproate, haloperidol, same thing. So options are A and C. Now, both of them are correct, but which one is the best? Best is always lithium and sertraline, right? Okay, so this is how you get your answer in the exam. Very important to understand the theory and then understand the question. We discussed about this persistent depressive disorder, which is dysthymia. If someone develops mild depression and present for at least 2 years, that's dysthymia or PDD. For this patient, psychotherapy is all that needed. Sometimes medication can be helpful also. Next is called cyclothymic disorder. One is dysthymia, another is cyclothymic disorder. A chronic disorder which is characterized by many periods of depressed mood and many periods of hypomanic mood for at least 2 years. You can say that if someone developed a mild form of bipolar disorder that persists for at least 2 years, that's called cyclothymic disorder. Okay. For these patients, better option will be giving some prophylactic mood stabilizers like lithium carbamazepine or valproic acid. So let's bring to a finishing of the bipolar disorder. Now come to grief versus depression. Very quickly, we'll go through that. Grief or bereavement is an important topic for exam. So what happens is that someone who lose a close relative, like let's say someone lost their wife or their parents or their sons and daughters. In response to that, normal person tend to get grief or bereavement like features. In that time, they will be sad, they will be tearful, they will have difficulty with their sleep, decreased appetite, loss of interest. So many features similar to depression, but they will not fulfill the MDD criteria. Okay, symptoms will not be persistent, it will wax and wane. Okay, suicidal ideation is very uncommon, but depression, suicidal ideation is very common. Grief usually gets better within 6 months. After 6 months, if still grief persists, it becomes a complicated grief or complicated bereavement. For grief, only treatment is supportive psychotherapy like cognitive behavioral therapy you can give, no need of giving any antidepressant. All right, so that's how we differentiate between a grief and depression. Depression, we only say it's depression if it fulfills the criteria. Otherwise, it's grief. Let's have a look to this question. A 50-year-old woman is taken to the hospital after neighbors find her wandering the streets, mumbling to herself and gesturing. When approached, she begins to cry and express thoughts about hurting herself. Examination reveals a scratch mark on both her forearm. When questioned, she reports feeling depressed since her husband died 5 months ago. She reports a decrease in concentration, feeling of helplessness, hopelessness, and hedonia, resulted in quitting her job and staying at home. She now has begun to hear her husband's voice, asking her to join him. What is the next step in management? Now, this condition is a severe form. Actually, if you look at here, this patient has developed psychotic features as well. Okay. Now, the most appropriate next step in here that you want to begin a trial of antidepressant medication, refer her to the psychiatry, ECT, assess thoughts about suicide, refer to the outpatient department for follow-up. Remember what I told to you, that if you think that someone is depressed, severely depressed, the most important thing that you rule out that is there any active suicidal ideation? That's this question. So first thing that you do, assess for thoughts of suicide. That's the first thing that you will do. And then obviously this patient might have suicidal ideation. You need to refer this patient to the hospital for admission because she has got active psychosis also. Clear so far, guys? Any question? If in your option is there is a, if remember one thing, Dr. Arushi, if in the option there is assessment for thoughts about suicide is an option, that means that you haven't assessed yet. Okay, so you need to assess it, like, is this patient having any active thoughts of suicide or not? Yes, Dr. Oishi, the treatment is same. Acute mania and hypomania, both treatment will be antipsychotics. Very good question. Pregnancy with bipolar, what will be the treatment? Good, very good. So that's one of the complicated topic, I would say, that someone having a bipolar disorder and that patient is on lithium and that patient wants to get pregnant. Usually we try not to give lithium during pregnancy because it can be teratogenic. But the option in here depends on how is the bipolar disorder. If the bipolar disorder is well controlled for at least 2 years, okay, if it is written in the stem that bipolar disorder is well controlled by lithium for 2 years, then psychiatrist can stop the lithium, so gradually tapering the dose and then stop the lithium and give a lithium-free pregnancy. Because patient is not pregnant yet. Before getting pregnant, patient came to you to get the advice. So that's one option. If patient is on lithium, but not well controlled for 2 years, then there is two options. One, if patient getting frequent bipolar disorder episodes, then we need to continue the lithium and let the mother know that, well, there is a chance it can cause complication to the baby, but we will follow up the child. Other option is that psychiatrist can withdraw the lithium for the first trimester because that is the time when baby usually develops all the organs. And if there is malpresentation, if there is any fetal anomaly occurs due to lithium, it usually occurs during first trimester. So psychiatrist can give a withdrawal of lithium for the first trimester and then restart from the second trimester. So these are the three options. If well controlled, then we reduce the dose of lithium and then stop it before patient getting pregnant and give a lithium-free pregnancy. If not well controlled for 2 years, then either continue the lithium throughout the pregnancy or give a first trimester free lithium. If patient is already pregnant, okay, and now patient continued lithium during that time, like let's say now he's 4 weeks or 5 weeks pregnant, then there is no way, even if you stop it, it's not gonna like change the outcome. So in that case, if patient is already pregnant and continued lithium during that time, just continue it and just let the patient know that there is a possibility of complications, but obviously we will follow up the child with doing ultrasound and everything. Okay, clear? So that's the pregnancy with bipolar disorder management. So lithium is a prophylaxis. It's not a treatment. That's the thing, right? It's a prophylactic drug. So it depends on that what is the status of the patient. Sometimes we can give a drug-free interval, like for the 3 months in the first trimester, we might not need to give any lithium if she is not getting frequent episodes of lithium, frequent episodes of bipolar disorder. And we don't need to give any other medication in that time. Next, come to the schizophrenia. Schizophrenia is a vast topic. We'll go through that one by one, but a lot of things that comes from schizophrenia and you need to learn it. So schizophrenia means psychosis in which a patient loses touch with their reality. Okay. Now, the prevalence of schizophrenia comes in exam. So general population 1%, monozygotic twin 47, dizygotic twin 12%, one schizophrenic parent 12% chance of having it in the children, two schizophrenic 40%, first degree relative 12%, second degree relative 5 to 6%. All of this came in exam. So very, very important. So please remember it. Now come to the diagnostic criteria of schizophrenia. To diagnose someone with schizophrenia, we need at least one of these three symptoms. So one is delusion. Delusion is an abnormal belief that even if you try to show the correct thing, patient will not deviate from their belief. So abnormal belief. Okay, like let's say a patient thinks that someone is trying to poison him. Okay, even though there is no one staying with that patient, but he thinks that someone is trying to harm him. So that's an abnormal false belief, which is a part of delusion. Then hallucination. So some patient can see things that others don't. Like let's say someone says he can see snakes or insects all over in the room, but when you look in the room, there is nothing. So this patient having visual hallucination. Some people can have auditory hallucination in which they can hear voices. Okay, some patient can feel sensations in their body, which is tactile hallucination. Like especially cocaine abusers feel like bugs are crawling in their body, and that is tactile hallucinations. Okay, so delusion, hallucination, and the other one is disorganized speech. Disorganized speech means you will not understand what they're trying to say. Okay, so at least one of these three should be there. With that, patient can have grossly disorganized behavior and negative symptoms. Negative symptoms, especially flat affect. That means they don't have any feeling. Okay, so flat or bland affect, that's the negative symptoms. So patient with schizophrenia, they will have disorganized behavior, they will have disorganized speech, they might have either hallucination or delusion or both. Okay, if someone only have abnormal belief but no disorganized behavior or speech, no hallucination, then you don't diagnose them as schizophrenia, you diagnose them as a delusional disorder. Okay, so there is a difference between these two. That's why I'm telling it in detail. Okay, so to diagnose someone with schizophrenia, we need at least one of these three, and either these negative symptoms or disorganized behavior. And schizophrenia only can be diagnosed if patient have these symptoms at least for 6 months. Okay, and it will obviously affect their social, occupational, and other functional life. Two types of symptoms are there for schizophrenia. One is called positive, another is called negative. Positive means a normal person doesn't have it, but schizophrenia patient have it. So delusion, hallucination, thought disorder, disorganized speech and behavior. These are positive symptoms. Negative symptoms means normal patient doesn't have it. Sorry, normal patient does have it, but schizophrenia patient doesn't have it. So normal patient have a normal affect or usual like a normal mood. But in case of a schizo patient, they have a flat affect. They have a poverty of thought, lack of motivation, social withdrawal, reduced speech output. So these are the usual symptoms of a schizophrenia patient. Sometimes always understand that if someone is under a drug, let's say an illicit drug, and showing the features of hallucination delusion, you cannot diagnose them as schizophrenia because then it becomes a drug-induced psychosis. Like let's say someone took marijuana, okay, or methamphetamine just yesterday and now showing hallucination, delusion, disorganized behavior. Is it schizophrenia? No, it's a drug-induced psychosis. Okay, so always we need to rule out this drug-induced psychosis before we diagnose someone with schizophrenia. Now come to the treatment. Treatment is important in here. No CBT will help. This patient needs to be admitted in the hospital. It is involuntary. Typical initial treatment in this patient is second generation antipsychotic. So either olanzapine or risperidone. If you need to choose between these two, as I said, we choose risperidone now. If response is inadequate in 3 weeks after starting those medication, then increase the dose accordingly. If there is no response after 4 to 6 weeks, then you can change to an alternative second generation antipsychotic. We don't use first generation antipsychotic anymore because it has a lot of side effects. But haloperidol, chlorpromazine, trifluoperazine, these are usually the first generation antipsychotic we used to use before second generation came up. But again, a psychotic patient can become quite aggressive and violent. Okay, in that case, maybe sometimes you may not be able to give them the oral medication. If a psychotic patient becomes violent, aggressive, then the protocol will be giving a haloperidol IM. You can also give olanzapine IM in this patient, either of these two. Usually we go for haloperidol IM. If that is not in the option, then olanzapine IM will be an option. Okay, so that's your usual antipsychotic medication that you give for a schizophrenia patient. Now let's say someone having a problem with compliance. Like you give antipsychotic orally, but patient is not taking it. So compliance issue, if it's a problem, then you can give them as a depot preparation. Like every 2 to 4 weeks, patient will come to you to get an injection. Like there are injection of fluphenazine, okay? And usually fluphenazine or olanzapine, those things you can give as a IM every 2 to 4 weeks. That's a depot preparation only given if someone having a compliance issue. The next thing is drug-resistant schizophrenia. If you give 3 antipsychotic drugs in their maximum dose, still patient is not improving, then we call it drug-resistant schizophrenia. The option is to give clozapine in that patient. So clozapine is also an antipsychotic, but we don't give it initially because it has a lot of side effects that we don't want to have. So if it is a drug-resistant schizophrenia, like 3 drugs in their maximum doses did not work, then we can give a trial of clozapine, but strict monitoring for blood dyscrasia and cardiotoxicity should be done. Why? Because it can cause your WBC can go down totally. You can develop agranulocytosis. So that's why patient with clozapine usually monitored with a complete blood count. And they can also cause myocarditis. So every patient on clozapine having a chest pain, you should always rule out myocarditis. You do an ECG and a troponin for that. Okay. Even after clozapine, if that doesn't help, the last option can be electroconvulsive therapy. Now come to the side effects of these medications. Antipsychotic medications, especially when we use the first generation antipsychotic, they tends to cause a lot of side effects. One of the side effects is acute dystonia. What is acute dystonia? You will get kind of bizarre muscle spasm, which affects the face, neck, and tongue. Sometimes you can get like the eyeball is moving or dancing, which we call oculogyric crisis. You can get opisthotonus, like the back can get arcing, so arcing of the back, laryngeal spasm. So mainly this patient presents with like sudden muscle spasm of their upper part of the body. Treatment is benztropine, IV or IM. Just remember how they present and what is their treatment. It comes in exam. The next is akathisia. In one sentence, it causes motor restlessness. So patient has been started with antipsychotic recently, and now patient cannot sit anywhere. He feels very restless. So that's akathisia. Treatment is that you can either reduce the dose or you can substitute thioridazine. Sometimes we use propranolol diazepam or benztropine also. Any of this we can try, but first option is reduce the dose. Yeah, anxiety-like symptoms. Patient feel really anxious, irritable, and restless. That's akathisia. Then come to Parkinsonism. It's a very important complication. So patient started on antipsychotic drug, now developed rigidity, bradycardia, slowness of their movement, bradykinesia, sorry. So patient started on antipsychotic. First generation or even second generation, especially risperidone, can cause Parkinsonism. So just few days after starting the antipsychotic, patient having trouble walking. So they're having gait disturbance. They're having slowness of their movement, bradykinesia. They're getting rigidity in their muscle. Okay, so that's your Parkinsonian features. In that case, first use like lower the dose of the antipsychotic, or alternatively, you can use benztropine or benzhexol. These are very good. Okay. The next is tardive dyskinesia. In this case, patient develop an abnormal involuntary movement of face, mouth, tongue, and limbs. So it's not a spasm like dystonia, it's movement, abnormal involuntary movement of the face, mouth, tongue. Usually it occurs months and years after starting the antipsychotic. In this case, if the best option is to stop the medication, if patient's psychosis is improved. If you cannot stop the medication, then you can use tetrabenazine. Okay. The last one is the neuroleptic malignant syndrome. Remember we told about it? So it's a fatal adverse effect that can develop at any time, even hours after starting the antipsychotic. Patient develop very high fever, muscle rigidity, altered consciousness. In this case, stop the medication. That's the first thing that you do. Then make sure patient is hydrated with IV fluid, because patient develop very high fever, even 40 degrees Celsius. Give them cool blanket, cold IV fluid. If it is very serious, like confused, coma, seizure happens, then you can start with bromocriptine or dantrolene. So dantrolene is usually very good in this case because it also helps with the muscle rigidity that patient having. Now look at this chart. It has a lot of answers to a lot of questions that come in exam. Okay, so now we'll go through this one, the important one. Don't get like overwhelmed looking into it. You don't need to memorize everything in here, only the important part. First, look at the usual medication that we use. Let's say olanzapine. What are its main side effects? It causes dyslipidemia. It causes hyperglycemia, that diabetes. It is a sedative drug. and it causes weight gain. So remember, I told that it causes metabolic syndrome. So all you can see, these are all metabolic syndrome: dyslipidemia, hyperglycemia, obesity, sedation. Okay, so that's olanzapine. Same like olanzapine, clozapine is also the same side effect. So it causes dyslipidemia, hyperglycemia, it causes sedation. It's a very highly sedative drug, and also weight gain. It can cause orthostatic hypotension also, or postural hypotension. Now come to risperidone. Risperidone doesn't cause metabolic syndrome that much, but it can even cause a little bit of dyslipidemia, hyperglycemia. But the main complication risperidone causes is this one, hyperprolactinemia. It's a very common, and this is one of the common cause why we need to stop it. So hyperprolactinemia, when prolactin is increased, patient develops whitish discharge from the breast, okay, and also they develop sexual dysfunction. So that's hyperprolactinemia caused by risperidone. It also causes orthostatic hypotension pretty commonly, okay, but it also causes dyslipidemia, hyperglycemia, but not like this olanzapine or clozapine. Then come to quetiapine. Quetiapine causes dyslipidemia. It causes hyperglycemia just like olanzapine. It causes sedation, not that much. It also causes weight gain. So if you see quetiapine, olanzapine, clozapine, these are more or less same kind of complication. Risperidone main complication is hyperprolactinemia. Now come to our friendly drug, aripiprazole. If you look at here, it doesn't cause much side effect. So in dyslipidemia, no. Hyperglycemia, no. Hyperprolactinemia, not at all. Sedation, not. Weight gain, no. So now the next question comes. A patient is on risperidone and she developed galactorrhea. What do you want to do? The next best option will be change this risperidone to aripiprazole because it doesn't cause any galactorrhea or prolactinemia. If aripiprazole is not in the option, the next best option is quetiapine. The other one, which comes frequently in exam, patient is on olanzapine and now developed increased glucose, blood sugar level, or developed like a immensely, this patient is gaining weight. So in that case, we switch olanzapine to aripiprazole. This is the only drug which doesn't cause weight gain. Okay, so these two frequently comes in exam. Please remember it. Now come to the other psychotic disorder. Very quickly, we'll go through that. Brief psychotic disorder. Brief psychotic disorder, it's a psychotic symptom, just the difference is their duration. So brief psychotic disorder means patient will develop psychotic features, but the duration will be less than 1 month. So patient will develop hallucination, delusion, disorganized speech, okay, grossly disorganized behavior also, but the symptoms will be more than a day, less than 30 days. So that's how we differentiate. Because this is psychotic, patient needs antipsychotic medication in here and hospitalization also. If you look at here, 35-year-old female Chinese immigrant brought in by neighbors after she was found wandering in the street. Whenever you see wandering in the street, think about psychosis or confusion. She appears disabled. This is grossly disorganized behavior. You learn that she arrived in the US several days ago and upon her arrival, witnessed the death of her 3-year-old son. While in the waiting room, she appears to be responding to internal stimuli. What this means is that if someone having hallucination, they will like they will pretend that they are responding to some unseen stimuli or internal stimuli, which we can't see. So you have got hallucination, you have got disorganized behavior, that's psychosis. The duration is less than a month, that's brief psychotic disorder. Okay. Now the same feature, but that lasted more than a month, but less than 6 months, that's schizophreniform disorder. So same presenting feature, but the symptoms are more than 1 month, but less than 6 months. Okay. The treatment is again same. Give it a read, this scenario, you will get to know it better. And schizophrenia means the symptoms will last more than 6 months. So there is brief psychotic disorder, which lasts less than a month. There is schizophreniform disorder, which lasts 1 to 6 months, and more than 6 months, that's schizophrenia. Very easy if you remember in this way. The next one is the schizoaffective disorder. What is that? Divide it into schizo and affective. What do you find? So patient having psychotic features, patient having affective features. Affective means they're having either depression or mania, hypomania. With that, they are also having psychotic features. So when a patient has both psychotic features, with that, either depression or mania, that's schizoaffective disorder. Look at this question. 25-year-old women found walking nude in the shopping mall. When asked why, she replies, I am making it easy for others to have sex with me since I know they all want me. She stated she heard a voice telling her she was irresistible and everyone wanted her. So voice means she is having auditory hallucination. When she speaks, she can't focus on one topic at a time. What is this one? Flight of ideas. Her mood is euphoric, affect labile. So what do you think? This patient also having mania, having hallucination. She recounts an episode last year where although she did not have an elevated or depressed mood, she heard voices she could not describe, okay, and believed others were following her. These symptoms lasted for more than 6 months and caused her to lose her job. So also functionality problem, it's more than 6 month duration. Now look at how we diagnose this condition. Patient in this case will have both psychosis features with either mania or depression feature. In this stem, you found that patient having hallucination and disorganized behavior. So that's psychosis. With that patient also having mania features. That fulfills the first criteria. With that, patient will have psychosis in the absence of any mood symptoms. Previously, if you look at here, she recounts an episode last year where she heard voices. That means she had a hallucination at that time. So patient will have history such as like this, that delusion or hallucination for at least 2 weeks in the absence of mood symptoms. Okay, so don't get into detail about it. If you get a question in which a patient has both psychosis and mania or depression, think about schizoaffective disorder. Okay, this patient needs hospitalization, and this patient, because it's both affective and psychosis, she needs both antidepressant and antipsychotic. But usually you can try with antidepressant medication first. If that's not effective, then start with antipsychotics. Clear, guys? Any question with the schizoaffective disorder? This is a little hard apart from others, but just remember that in schizoaffective, patient have both psychosis and either depression or mania features at the same time. The last one will be delusional disorder. Remember, I was talking about delusional disorder. Very important. It comes in exam in many ways. Look at this question. Mr. Smith has been married for 10 years. During most of those years, he believed his wife was trying to poison him to get his money. So this is an abnormal belief. He frequently complains of stomach pain, which he believes is due to poison in the food. His thoughts are logical and coherent, which means he doesn't have any thought disorder. Very important. He denies any hallucination. No hallucination, no thought disorder. His wife, an independently wealthy woman, doesn't understand her husband's logic because she has more money than he does. Okay, so what he has, he only has delusion, abnormal belief, no hallucination, no abnormal or disorganized speech, no disorganized behavior. So it's called non-bizarre delusion for at least a month. What is non-bizarre and bizarre delusion? Non-bizarre delusion means that abnormal belief which has a possibility that it can happen in real life. Okay, but bizarre delusion is more commonly found in schizo patient. Bizarre delusion means that the belief which is very unlikely to happen in reality. Like if I feel like I have worm in my brain, okay, or if I feel I can see my soul walking in front of me. So these are called bizarre beliefs, which are more common in case of a schizophrenia patient. But delusional disorder patient only have non-bizarre delusion, okay? And the very important finding that it doesn't impair their level of functioning. There is a question, very common one, like a university professor is having a belief that aliens from the other part of the globe or planet is going to attack our world. Okay, and he is very absolutely sure about it. But on the contrary, he is a professor, and his level of functioning as a professor has not been impaired. He doesn't have any hallucination, no other abnormality. So that's delusional disorder, right? So always remember, delusional disorder means patient will have only abnormal belief. It doesn't affect their level of functioning, and they don't have any other hallucination, poverty of thought, disorganized speech, nothing will be there. Treatment, outpatient treatment is usually preferred. In this case, again, patient might need antipsychotic medication. Let's solve these two questions and then we can finish. A 37-year-old woman is brought to the emergency department by police after she was found trespassing on a famous film actor's estate. The patient is excited and says that this is all a big misunderstanding. She explained that she was only trying to leave the actor a surprise gift and a note and would never harm him. She recently received a signed photograph in response to one of her letters and keeps it in a box filled with newspaper magazine articles. Patient says, for now, we need to keep our relationship secret so his wife won't find out. Although she hasn't met the actor in person, she is convinced that they will be together someday. Patient has worked for many years as an administrative assistant. Although she has no difficulty performing her job, she keeps to herself as she feels that her co-workers do not understand her special relationship. On mental status exam, she is calm and cooperative, speech is non-pressured, goal-directed. Patient says her mood is wonderful because I am in love. Which of the following is the most likely diagnosis? Okay, what do you think? It's a bipolar disorder manic episode, borderline personality disorder, delusional disorder, narcissist, schizoid personality disorder, or schizophrenia? Yes, this is absolutely delusional disorder. Why? That only the abnormal belief of this sacred relationship This is the only thing she is having. She is working in the administrative assistant. That's a very important clue that this is not mania. Her speech is non-pressured. So all these things rule out manic episode. Okay, so that's your delusional disorder. Yeah, non-bizarre delusion. Okay, and others, obviously it's not schizophrenia. You don't know this personality disorder yet. We haven't discussed it, but these are not any personality disorder. Okay, so this one we can do it later on. That's fine. Let's start today's session. So, guys, this is exactly our first class on psychiatry. We try to cover the important topics, making sure you know which theory you guys actually need to learn. Okay, focusing on the important topics because no one can remember a lot of things. Okay, so important things, you need to understand which one is important, and then everything should be fine. Now, I understand that you might have a lot of questions in your mind about our course. So before I get to your questions, I would like to answer every question that you are having, but just have it go through this video. And then if still you guys are having any question in your head, just ask me. Okay. So feel free to ask me any question about the course. And obviously, you know that a free 2-week session is coming up from 31st of August. And there is also another question solvation class on 29th August. So we'll see you again, but let's have a look to this video on our course. Sorry, the sound was not on. All right. So thank you so much, guys, for watching the video. So do you guys have any question on the class and everything? So just to give you an idea that this course is a 5 months course, and you can understand that you guys will be with us for the 5 months. And that's really important because lots of course will finish in just 1 month, and then you'll be left behind and you will not know what to do, because in 5 months you will get to know with the course, with the materials and everything, and you will get us in every moment in your preparation. And that's very important. And after 5 months, if you really work hard, you'll just take like maybe 2 months to wrap up your preparation, and you should be able to get your exam. So 6 to 8 months is the maximum time that you should take to appear in the exam. Okay. Most of the candidates who usually appear from the course, they usually pass in the first attempt if they don't do anything wrong. Like some candidate, if they don't prepare well and they just appear the exam, then that's nothing we can do in that part. But obviously someone is well prepared and followed everything, they usually pass from this course. And we have a tremendous amount of past candidates, and still a lot of candidates are under us which preparing. The most important inclusion in this course is that we take one class every week just on question solvation, the recent questions, and like mainly the sample questions, how to solve the questions and everything. We take a class on that every week. So previously there was 2 classes fixed, and sometimes we would take another extra class. But now the fixed 3 days class in every week, one class particularly on solving questions, is very, very helpful for even beginners. Okay, so it's a very important inclusion for the course now. And I guess that if you follow the course properly, if you follow the theory followed by question solvation, you get into the software, go through our questions and see how you are doing, and then appear the exam, there is no way you will fail this exam. Yeah, everything will be given. The whole material will be given to you. Usually, once you are added in the software after the payment that you have done, then you guys will get the full software access and everything. Then you will get the classes, the notes and recordings, everything. The next session is on 29th of August. Okay, so, and after that, from 31st of August, the main class will start, the course class. And the first 2 weeks we will take, that will be free. Any of you can join the class. We'll take it just like how we did today. The question solving classes are subject wise. That means when we finish cardiology, we do cardiology question solvation. We also do month-wise question solvations. Okay, so all the sample questions we try to solve for you. Obviously, it's a lot of work that we do for you, and also we expect that you will do your own part as well. So you will get the whole schedule just within few days. That the initial first 2 weeks schedule will be given in the First Aid AMC MCQ group. Please make sure that you keep on your eyes. So right now, the weeks that we are taking the classes is fixed. Obviously, we are taking classes in this batch is the MCQ class were on Friday and Monday. So Friday and Monday, and also Thursday. Okay, Friday, Monday, and Thursday. These 3 days is your fixed classes. But in the new batch, this thing can get changed, but we will obviously let you know the 3 days that are fixed. The classes are usually fixed days. The last day of admission is within those first 2-week session. But obviously, I would suggest if you are looking for a course, get into it, because there are obviously limited seats for this course. And I would suggest you to get your place before it becomes totally full. All are live lectures, okay? But recordings are given for those who miss the classes. The classes are 2.5 hours. Okay, so a lot of things are included in here. I can't think about anything which we are not doing for MCQ. So we are doing full theory, all the detail from GEM and everything. We are doing subjective question solvation, monthly question solvation. You will get into the software and you will get a lot of questions in the software just to appear mock exams. So there are full mock exams, like 150 questions. There are mini mock exams. Everything is in there for your preparation. Okay, we have a long list of question solvation from 2018 in the software. If you solve those things, there is no way you will fail the exam. Yes, if any of you are appearing exam this year, and if you have already got your exam date, what we can do, we can add you to the previous batch recordings. You can go through the previous batch recordings, and also you can just join the live session with the new batch. Okay, that's fine. So if you're going for exam in November, Dr. Edward, so I would suggest just enroll the course as soon as you can, make your payment, and just send us a message showing your placement letter that you have got a date in November, and then we will give you the access of previous batch. It's only for those who are appearing this year, because I know that we'll not be able to finish this course this year. So for you guys, if you are appearing in November, December, or anywhere in this year, you will get the full access to the previous batch. Okay, so it's very nice to see you. A lot of you are here. We'll see you soon in our next class also. So in that time, if you have any questions, feel free to ask me, or you can always email us at firstaidamc4536@outlook.com. Let me just write it in the chat box. Okay, so you can always email us here for any inquiries that you are having. What topic is the next class? Next class is on question solvation. There is no topic on that. We will just show you how to solve questions. And then the 31st August, we will start from cardiology. Okay, so thank you everyone. Have a good night and see you soon.